For those of us in the medical community, these are uncertain times. Like the search for PPE, the search for the right answers during the COVID-19 pandemic can be harrowing with conflicting reports, a barrage of news updates, and thousands of sudden medical experts flooding every single one of our social media feeds. But this is different. This is Velocity from Vapotherm. We bring you conversations with fellow medical experts, RTs, physicians, nurses, and researchers alike. In this episode, we join a conversation with ED physician Dr. Kirk Hinckley, researcher George Duncan, nurse educator Jeannie Pedanici. Each of them are members of the Vapotherm team, Director of ED Education, VP of Science and Innovation, and Clinical Nurse Educator. In this episode, we join them in a roundtable discussion with Director of Medical Affairs Jeff Maglin. Now, it's worth noting that Vapotherm does not practice medicine or provide medical services. Any recommendations that come up in these conversations are solely those of the speaker. Today's conversation joins our roundtable in a discussion of safety during the COVID-19 pandemic, as well as options for treatment.
There have been concerns raised about the efficacy and the safety of high-velocity nasal insufflation, high-flow oxygen, and NIPPD on these patients, with some organizations recommending going straight to intubating patients if they fail conventional oxygen therapy. So let's first start on the efficacy, and I'll ask George this question. Have you seen any statistics on the success rate of high-flow, high-velocity on these patients? And if not, is there any research that might predict how well high flow or high velocity might work on these patients?
That's I think a really important question, Jeff. And unfortunately, this is such a new experience that I haven't seen anything that's been collected systematically. So there's increasingly clear guidance from a number of organizations around the world that the use of high flow nasal cannula after conventional oxygen therapy fails is important and appropriate. And most of the rationale that's derived, that is derived from, is really around what we know about the high flow delivery of oxygen to patients in type 1 failure. So in the adult context, we know that there is a tendency towards lower intubation rates versus conventional oxygen. There have been meta-analyses, systematic reviews that have shown that. The FRAT study, the DOSHI study have demonstrated efficacy in the acute management of type 1 failure for patients presenting in respiratory failure in the emergency room. It's important to note that that part of the question here goes to really the mechanics of how we're going to manage these patients. And as Dr. Hinckley said, the alternative is early intubation, which may end up being necessary for a fair section of these patients, depending on how they present clinically. But that's not a completely benign alternative for a couple of reasons. One, because of the incredible aerosol risk. It's probably the most risky procedure clinicians can do in terms of personal exposure. The other side of that is just the mechanics of healthcare delivery. Right now, we're looking at a ventilator shortage. We do know from the experience during the SARS epidemic that healthcare workers who were exposed to high flow nasal cannula were not at an increased risk of developing the disease. So if we are able to provide a safe bridge after conventional oxygen therapy fails, prior to making a decision to ventilate the patient and exposing the clinician to the risk of doing the intubation, as long as we can perform that safely, the societies are, I think, coming to the conclusion that this is a completely reasonable adjunct. Uniformly, when you look across all those societies also say that these patients are at risk. So you need to perform very close monitoring for decompensation. I believe the World Health Organization suggests that, especially in the first hour after you initiate the non-invasive therapy, you need to be prepared to make a decision to escalate that patient if necessary. we will hopefully be collecting data throughout this entire experience, Jeff, and we're going to know a lot more in about 6 months.
Initially it was all just go straight to mechanical ventilation for these patients, get them intubated, but kind of learning about the, obviously that's a significant risk for the healthcare providers, for the transmission, and just the fact of the limited resources. So I have been starting to hear more instances of using HVNI for, COVID-19 patients for kind of that mild to moderate respiratory distress, sort of as that intermediate step from the conventional oxygen therapy that may be an alternative to intubation and mechanical ventilation, or, at least hold them off. As we know, we have to take caution with these patients because they've been shown to deteriorate rapidly. So it's, like George mentioned, requires close monitoring. We don't always know, where the course is going to end up, but it can help preserve some of the resources. Seen some, reports of patients who were, fairly insignificant, respiratory distress, that moderate distress. They were able to get them on, usually put them on higher flows, up to 40 liters, that 100% FiO2, because of the hypoxia. And, the patient did respond and had some, had the decreased work of breathing. So they were able to at least keep them on for that time being, and keep a ventilator available. I think as the volumes of the COVID-19 patients increase at some institutions and the resources become strained in many of these, affected areas, the clinicians are beginning to consider what are some other options that they need, particularly as early intervention for treating, these patients with hypoxemic respiratory failure.
It really depends on where they come from, but the issue is twofold. So one, they're trying to conserve their ventilators, right? So your regular non-COVID patients that might require ventilation or some sort of ventilatory support, these are patients that they're really trying to conserve their vents on, right? So they're really taking those considerations a lot more, putting a lot more diligence into that. Just because if you have a CHF or COPD that maybe has been in and out of your ICU, that you really want to keep them out of the ICU as best you can, knowing that COVID is either in your town or coming to town. The second part of that is we've got really, and unfortunately it's kind of the best we have right now, but anecdotal evidence from internationally and also from domestically, with stories like as early as the cruise ship, and then in places like New York or New Orleans, where high VNI has really been used exclusively in the smaller communities to try to hold some of these lower acuity or less acute patients out in the community. Now, the sicker patients, a lot of them are getting transferred to the big centers. And if you hear the anecdotal stories from there, they will tell you, yeah, there's a lot of people that progress very quickly to respiratory failure requiring mechanical intubation or ventilation rather. So the success stories there are one, trying to keep the ICUs offloaded by lessening the amount of time that these people are on the vents, right? So it is a weaning strategy as well. They're using high VNI to try to get that patient off the vent maybe a day sooner than they would have been able to successfully wean otherwise. So think mild to moderate symptoms, hypoxemic patients that are using increasing amounts of nasal oxygen, 2, 4, 6 liters. Again, these are patients that you're not going to want to go ahead and use any type of mask on. We know that the masks are a significant risk, and specifically manipulating a mask in any way is a significant risk in terms of aerosol generating procedures. So, taking that patient that's requiring just a little bit of oxygen and thinking about early use of high VNI has been a rescue strategy for a lot of these places.
And just a statistic related to the last discussion, from the Chinese experience, we know that over 60% of the patients that were critically ill, so the patients that ended up in the intensive care unit, were on high flow nasal cannula. So it has been extensively wrung out in these patients. As it relates to the risk, that's really the big question. Anybody who's ever done any ventilatory support procedures, so respiratory care, they're definitely not strangers to what they call aerosol generating procedures, AGPs. Every clinician knows it, and frankly, it's why when these patients present, the first thing you deal with is PPE and environmental safety. You'd be really hard pressed to find a more risk-prone procedure than endotracheal intubation from a nosocomial standpoint. It's a proven high-risk procedure. But when it comes to some of these other technologies, there have been concerns, and I think it's important to take a step back and look at the science. So people have studied it. People have looked at the whole constellation of procedures, specifically in the context of what's the transmission risk, what's the deposition risk of some of these aerosols out of the procedures. Turns out, if you go back to the work by Hui and colleagues, that amongst the whole family of respiratory therapies that are commonly employed, high-flow nasal cannula is low on that risk list in terms of airborne risk. I think that it's important to evaluate the science, what we know about these procedures. I think it's important to put it in the context of what we know from the early SARS experience, that caregivers who were exposed to patients on high-flow nasal cannula were not at significantly increased risk of receipt of the disease. So, but it is an important question, and frankly, it's a question that we take really, really seriously.
I know that you've done some work as far as trying to understand transmission risk and how to mitigate it. Could you talk a little bit about what precautions you would recommend to minimize transmission risk when using Hi-VNI?
So there's the absolute stock standard. Of course, you're going to do personal protective equipment. You're going to obey all the environmental controls. You're going to use negative pressure where available. And for management of these patients, those are kind of motherhood statements. There was a proposal out of China. So this came from the Chinese Thoracic Society's guidance on their experience with their COVID-19 patients. And it was simple, it was actionable at a clinical level, and intellectually intuitive. So we actually studied it. And what they were proposing was put a simple surgical mask over the patient's nose and mouth whilst they're on the therapy. We studied that using computational fluid dynamic modeling. Our model looked at Hi-VNI therapy on an anatomically competent CT-derived model generating human breathing patterns receiving 40 liters a minute. And we compared it to oxygen at 6 liters per minute via standard nasal cannula. And we also compared it to tidal tachypnic breathing with no therapy. What we wanted to find out was what happens when you apply that surgical mask to these patients. And what happened was we found that the mask model captured, in the case of HVNI, over 83% of the mass of the particles that were generated in the simulation. And we were using mass proportions that are derived from the literature to reflect what actually comes out of these patients. So it was physiologically plausible. That's actually an interesting comparator. We looked at the numbers that came out of a mask model over a standard nasal cannula at 6 liters per minute, which only captured 74%. And that probably has to do with the velocity, the outflow of the gas. 87% for just normal tidal breathing patients. So I think what that showed us was that the mass of particulate matter was efficiently captured, largely because the mask did what we would expect it to do. It received this bolus of air. That high velocity flow ends up diffusing into the mask, slows that gas flow, and it allows the mask to do what masks do, and that's capture stuff. What we did see was that around the matrix of that mask, in the model, we had purposely built in gaps. So we purposely built this as a really, really bad application. So for example, in the model, we modeled somebody that didn't crimp down the nose piece. And that was where the leaks occurred. So the moral of the story here is the mask seemed to do a good job capturing the expired particulate matter, and make sure you fit your mask well on these patients.
What I was hearing from emergency physicians and respiratory therapists is the scene is not safe, right? And specifically with regard to high flow nasal cannula therapies like high velocity. And so we wrote a protocol really to address the safety concerns and also the applicability of the technology. And to start, it's something that we think should be initiated early for any patients presenting with mild to moderate symptoms of a suspected infectious cause of respiratory distress. So certainly you're not going to know right away unless you're in an endemic area for COVID, but that would include those COVID patients as well. We also included Vapotherm as a option to help wean patients from ventilators. We also considered the fact that heated and humidified gases aid in mucus clearance and support the natural mucociliary functions of the lung. So, and in addition to that, mitigate cough. And so those would be indications to use the therapy as well. Now, keeping in mind what George just told us, and use under a surgical mask is really paramount as part of this protocol. So how do you actually use it is really no different than you would use it on a non-COVID patient. Now, there has been some suggestion that flow rates less than what you might use in a non-COVID patient should be considered, but really with the known failure rates or the known intubation rates, that doesn't make a lot of sense. And so George told us about using kind of worst case scenarios in his modeling to look at, hey, what about at the highest flow rates? Our device goes to 40 liters. Can we safely do this under a surgical mask at 40 liters? And I think his data has proven that, and that's why it's included in the protocol. So we do not recommend any type of deviation from your normal use. So your flow settings are going to be identical to what they would be prior. Your FiO2 is completely titrated separate to that. And your temperature, we always recommend that the patients are set about to body temperature, about 37 degrees. Again, our device supports a maximum of 40 liters. And as long as you got an adult patient, you can go up to 40. Now, for pediatric patients, we do recommend about 1.5 to 2 liters per kilo in terms of your flow rate. And I think Jeannie will talk a little bit more about that. Now, how about keeping your staff safe? What are they going to do with these units when they need to be decontaminated? And that's included in the protocol as well. So we do recommend the disposable circuit that's used with the Vapotherm device can be removed completely. It's a closed circuit and then disposed in your biohazard bag. So a sealed biohazard bag and then a 5-minute wipe down of the unit, and it's ready to go for the next patient.
I think that one of the things that we're seeing during this rapidly evolving pandemic is the aggregation and dissemination of ideas and guidelines. There was a particularly useful guideline that was posted on the journal Critical Care Medicine from the Society for Critical Care Medicine just recently that is a good example of aggregating best thinking, where they've actually weighted evidence and tried to make I think very good real world sorts of recommendations and suggestions. There's a difference. I would refer people to that guideline and others. They're coming out every day, but that's I think a particularly well thought guideline. And we're seeing now guidance from everything from the World Health Organization. There's incredible country guidance that have come out of China, come out of Italy. We're seeing guidelines that are coming out of, there's one consensus or position paper between a number of societies in Germany that have been particularly good about highlighting decision making in terms of escalation. So this is going to be evolving, and I'm sure you'll be hearing from us as we continue to move through this.
I would just say that this is a moving needle. When we first started seeing COVID here in the US, I think that the general consensus was that one, high flow nasal cannula therapies are not safe to the healthcare providers, and two, that it just doesn't work for this illness. And what we've seen over the last couple of weeks is that a general 180 on that stance, right? So any type of consensus data early on was, hey, don't use it, it's not safe, and even if you do use it, it's not going to work. And I think that we've kind of proved, especially with George's transmission assessment, that one, it is absolutely safe to use for the caregivers, right? You apply a surgical mask over the nasal cannula and you provide the therapies as you normally would. If you do them early in those patients that are mild to moderate, maybe you can stave off severe disease. Even in your failures, you might prevent that patient, or you might lessen the course on a ventilator by a day or more. Furthermore, you might be able to wean them from the ventilator earlier than you ever could before. So some might consider that a failure. I consider it an opportunity to keep patients off of vent. The idea of early intubation is also, like, hey, I'm going to protect my staff. Well, we know, again, that's hooey, right? Intubating these patients, and there's new devices come out to mitigate the different aerosols that are generated during the intubation process. But hey, this is a really risky proposition. So if you can avoid that process, or if you can put it off to the point where maybe you have more staff, or you have you can do it in a more controlled setting, then it makes sense to put a patient on a nasal cannula and deliver therapy like this. I think if you look at the SCCM guidelines, you'll really see that shift put into words. And then furthermore, I think the EMCrit or emcrit.org's website has done a really nice job of up-to-the-minute delivery of information. And they too have done this complete 180 on high-flow nasal cannula therapies. And I think that's for the benefit of the patients.
Thank you very much, Dr. Hinckley. And finally, Jeannie, any final comments or thoughts?
Well, actually, I'd say that John and George and Dr. Hinckley summarized it very well, and I agree with all their comments. Things are changing daily, so we're definitely keeping up on the current recommendations. I'd also just like to say that I want to extend a sincere thank you to all the healthcare workers for their dedication and extraordinary contributions during this challenging crisis, and we're very grateful for that. So thank you.
Thank you. So thank you, George, Dr. Hinckley, Jeannie, and John for your time. We hope you, the audience, find the information from this panel discussion useful. Our plan is to continue to post helpful content during the course of this epidemic that you can find on our dedicated COVID-19 webpage. Email us at info@vtherm.com if there are other questions that you would like us to address, or you can call us at the Vapotherm COVID hotline at 833-333-2770. So thanks again and have a great day.
Thank you for joining us, and we hope you enjoyed this episode. If medical devices came up anywhere in that conversation, do make sure to check your instructions for use for full information. If you're looking for more information about Vapotherm or anything that you heard in today's conversation, you can probably find it online at www.vapotherm.com. In the resources section, you'll find our updated blog with new articles every week. You'll also find Vapotherm Academy, an on-demand learning platform that even has some CEUs for RTs and contact hours for nurses baked right in. You can find that at academy.vapotherm.com. Thank you for joining us for this. We hope you enjoyed. Please share it along. And most importantly, please be safe out there.